Thank you very much, Alberto, for this very nice introduction. It's an honor. What I'm sharing with you today are a few ideas that we have developed through the years and hints for future developments in the field of laparoscopy and endoscopy. As a professor of robotics, I tend to show some little story just to remember where we come from and where we are. Essentially, modern surgery, the one that you are using and presenting, is the result of the convergence of a number of scientific and technological achievements through decades, including the advent of endoscopic instruments and birth of minimal invasive surgery. And also robotics, or more properly computer-assisted surgery, should be seen as the last step of an evolution that essentially derives from the explosion of imaging and from the progress of robotics. And the objective of robotics are for all very clear. So more accuracy, that means more predictability, more repeatability, so in one word, more quality. And after some years of pioneering research, this is now a very establishment requirement. So all success stories, the Da Vinci, the CyberKnife, are the result of this concept. So higher quality and value for price. That, of course, is quite high. So based on this background and on the fact that most of the robots that have been developed in the past were external robots, we believe that a new frontier are endoluminal robots. And there is a reason for that in addition to many other. But please consider what is happening again. What will be the next step for convergence? The next step for convergence will be molecular diagnostics or related techniques. That is, the fact that more precise precision surgery will be needed derives from the fact that more accurate and early diagnosis will be performed. So it is clear that thanks to what is happening in the area of molecular diagnostics, imaging, and so on, surgery will more and more become, I would say exclusively, except for emergency, be a fact of accuracy. So minimal invasiveness will not be just related to patient comfort, aesthetics, and so on, but also intrinsically to the fact that surgery will become like shooting at a very, very precise target. We have been investigating this according to many different principles. For example, we started from a colonoscopy, and actually this is a very interesting and also fascinating idea, because this idea was originated by a very creative surgeon, Professor Andrea Pietrabissa at that time, who observed that the worm has outstanding locomotion capabilities and suggested to us that possibly a painless colonoscopy system could be designed based on this analogy. And after years of work, we were been able to develop a painless colonoscopy system that is inchworm, that is now in still advanced clinical experimentation, and a significant number of cases demonstrated that this colonoscopy is effective and also objectively painless. So, but then, of course, more can be done according to this principle. Actually, we moved from wired painless colonoscopy to wireless GI endoscopy, also taking inspiration from nature, and developing legged capsule to increase the active behavior of the capsule. Because as we know, endoscopic capsules, although very successful, are mostly passive devices at this time. They just move depending on peristalsis, and so it is desirable, highly desirable actually, to incorporate some degree of control. And we did it, for example, in this case for gastroscopy, that is, it's a floating camera that can be teleoperated from outside wirelessly, and that, of course, includes a camera for gastroscopy again, or and this is the technology that we use now more and more extensively, adding locomotion and orientation capabilities, like in this case, using magnets, external magnets and internal magnets. A combination of the fields allows, as you see here, essentially controlling the capsule wirelessly, that is really, and as a telemetry system, so transcutaneously, with no harm for the patient, and adding tremendous capabilities to the capsule. And this is what we are doing. Actually, we have developed a family of capsules like these ones. Those are the results of a European project. And we have validated them, assessing all the electrical and optical capabilities. And this is an example. This is the case presented by Professor Schur from Vesco Novinion of the potential of this concept. You know, the capsule can be brought anywhere virtually in the gastrointestinal tract and used to release, like in this case, a superelastic clip that provides hemostasis. But this is just one case. Incidentally, this has been a very successful case. But it, I think, is a hint for many, many different techniques that essentially remove the cable, okay, between the end effector and the external world. And so many things, you see, this is the release of the capsule. So this concept can be used, and we are thinking of using, to develop an entirely new generation of endoscopic active tools that, like in this case, can perform. Other cases are, for example, biopsy, or can deliver medicated micro and nanofilm, so precisely intraluminally. And I think this is really limited only to your and our imagination, what we can do with this technology. This, in fact, also attracted the interest of many different magazines, of course. This is the result of some joint work that has been performed between our group and the group of Professor Morino and Arezzo on how to control, because obviously one could say, are the average doctor, endoscopist, or surgeon able to control this new generation of wireless, because I insist on this concept. It's really completely separating your hands from the tool. Okay, the capsule is flying, is floating inside the abdomen. Are we able to do that effectively? And the answer, Professor Arezzo has already presented some results on this, but I can anticipate that based on significant statistics analysis, essentially, this is feasible, and the teleoperated control methodology works very nicely. Surgeons, I would say, a doctor, especially young, but not only young surgeons, very effectively use and accept this kind of teleoperation. So from a point of view of usability, this technology is very promising. And one can think this is just another example of imaginative approach. What we thought a few years ago is, well, can we use, rather than one capsule, many capsules? Can we swallow not just one capsule, but many capsules? Each capsule having a different function. One capsule could be a structure, one a joint, one a battery, one can be a camera, one can be another kind of tool. And the idea is, can we assemble this capsule together and eventually creating a new new instrument, surgical instrument, or any kind of instrument, and we can reassemble and then disassemble all these. It's not easy, but it is certainly possible. And again, I just leave to your imagination the concept or inventing new ideas. Those are modules that we have built, and this is that it works. And what happened? Sorry, this is not my computer actually. This is a sort of spider structure that can be envisaged. Well, this was at that time research, but shortly after became a real project that in fact is called Arachnes. That is, is the Greek name for spider. And we see this as the latest, it's not certainly the final, the next step of evolution of surgery from external instrument to internal. It is clear that this is exactly what can be envisaged using single-port laparoscopy, because the concept of this dexterous instrument is very much related to the idea of this endoscope. This is the European project that I coordinate that is called Arachnes, that is aiming at designing this entire system with two kinds of access, actually. One abdominal, so single-port laparoscopy, and one transgastric or intragastric or esophageal. So both approaches are possible with this technology. So the idea is building gradually all the operating room tools, all the essential ones inside the abdomen of the patient. Actually, this can be done in different districts, but we focused on the abdomen and through single-port laparoscopy. Actually, those are the two concepts that we have envisaged. So this is the idea. This is the single-port laparoscopy bimanual robot. This robot has been, this manipulator has been designed. The idea has been proposed by Professor Alfred Cuschieri. Sorry, this one is actually the next, probably. Okay, oh, sorry. Maybe I... Okay, this one, sorry. This one is the first animation. So the idea is, you can see the animation. The idea is to use a single port access and many kind of cameras. These cameras have been developed by Storz. It's a panoramic camera, so wide field of view, plus a 3D camera, and then different tools. Those are not really swallowed. There's, of course, is a practical evolution, if you will. Those are inserted through the trocar, and one arm, then a slit, then a second arm, and then the two arms are locked, and full dexterity can be reached through a single-port laparoscopy system. So this is essentially the idea. This, of course, is a simulation. Very interesting is an additional option that we have. The port has access for many different sensors, including sensor for optical biopsy, if you will, or biochemical sensors to sense, for example, for pH, for many fundamental parameters inside. So again, the idea is to create an operating room through the single port instrument. And all this has been developed, most of it. Those are the arms. I don't have too much time, but these arms reproduce the dexterity of the two arms, essentially, of the surgeon. Plus, there is an external robot. So a total of 18 degrees of freedom have been obtained. This is the external shoulder. And those are tests that have been performed by a number. So far, already 10 surgeons have tested with a standard test for dexterity and acceptability, usability, this instrument. I would say the general acceptance, we have, of course, results that have been or being published, but the general acceptance is pretty high. Of course, some improvements are needed, but the concept and implementation work quite nicely. Also, as I said, as a research approach, we can think of another idea, that is inserting different micro-robots through the esophagus, so through with this kind of technique, and using external magnets that can be controlled by robots to increase accuracy or manually. And the idea is to control through the skin many different tools. So please consider this option, okay? And the many possibilities that could arise based on this idea of decoupling, essentially, external from internal, removing rigid tools or even cables. Of course, cables are needed in many cases, but maybe not for control. And so this is, again, it comes back the idea that you have seen in the animation of building a robot with many degrees of freedom inside the abdomen, in this case of the patient, without any visible scar. Okay, and this is what we have done. Okay, so and as an example of what we can do, we can move a camera like this. This camera is moved, of course, this is an in vitro test, but this camera is steered, oriented, moved anywhere just by using an external magnet. So you see that this is it's a very, very broad field of possibilities that can be envisaged using this technique. You remember the worm. Bio-inspiration comes back. This time we took inspiration not from the worm, but from the octopus. An octopus is an extraordinary creature, and we have built and we are imitating the octopus capabilities of virtually infinite degrees of freedom. This again was a dream, was an inspiration. Well, this became a project. It's a European project that in the next 4 years will develop an entirely new generation of endoscopic instrument based on the concept of the octopus arm and on very, very groundbreaking technologies that we already have in part and we are going to develop. So, one more. Ideas. And of course, the quest for miniaturization is not over at all. We have launched a new project in which, from the centimeter scale, move toward the millimeter scale and lower. This is a project just started for vascular diagnosis and therapy, and the concept is very similar, so millimeter-sized capsule to reach even smaller district and sites to observe, to release, to care, to intervene. And this is always the idea. So vision-guided, many sensors on board, teleoperation, magnetic, so wireless guidance and so on. And this is the test bed for this. So, conclusions. Well, one conclusion is that biorobotics and robotics technologies are and will fuse with nano-engineering, molecular diagnostics for making intervention much more effective, earlier and effective, and to launch, so to implement this concept of precision surgery more and more. Robotics technologies are mature, are well established, are cost effective, and progress is steadily occurring in the miniaturization of robots for endoluminal therapy. The advantages of robotics, so accuracy, repeatability, motion control, image-based planning, intelligence, learning, cognition, can be very useful for many new applications. And really we believe that collaboration on validation and on the development of new solutions jointly by surgeons and roboticists in these fascinating and promising areas are important, possible, needed, very welcome. Thank you very much.
Professor Dario, it's 15 years I know you, and anytime I hear you speaking, you're still impressing me a little bit more. No words to thank you for the privilege of being with us today. I would like to ask, although this is just a lecture, if there is any short question from the audience. If not, I would like to do one, and this is everything that you have shown from electromechanical devices have a limit of miniaturization. What do you think is the limit today? Is stiff flop a solution to enhance miniaturization?
Yeah, I think that miniaturization is a technology that is is being developed in many different fields. You know, in microelectronics, they talk about more Moore. That means the Moore law, doing things smaller and smaller, but also more than Moore. That is developing things that are not only flat but three-dimensional, made of different things. And the area of nanotechnology, new materials, microelectronics, MEMS, together with system science, that is essential robotics, are making these things absolutely practical, in my opinion. So we are, as researchers, we believe that the centimeter range is now essentially close to possible industrialization and clinical application, and that the new frontier is the millimeter range. And since we are researchers, we are going to explore this domain, and I'm sure that in 10 years from now, we or you, I don't know, will enjoy seeing clinical application of this new generation of miniaturized instruments.
Thank you very much again for the privilege. I would like to thank you with a further applause. And I think I have to